the appointed hour. I'm Dave Potenziani. I will be hosting the seminar today, but our speaker, Dr. Chuan Hong, will be introduced by Dr. Ed Hammond.
Thank you very much. I am delighted to introduce and present my friend and colleague, Dr. Chuan Hong, who will be doing our presentation today. Dr. Hong is an assistant professor of biostatistics at Duke University. She received her PhD in biostatistics from the University of Texas Health Science Center at Houston. She has been a postdoctoral fellow in both biostatistics and biomedical informatics and an instructor in biomedical informatics at Harvard Medical School. Her primary research interests have been focused on developing statistical and machine learning methods, emphasizing artificial intelligence in healthcare systems, predictive modeling, high-throughput phenotyping, and precision medicine using large-scale biomedical data. She has an extensive experience in data harmonization based on representation learning, information retrieval, language models, and fairness-aware predictive modeling. She's published over 100 peer-reviewed papers in leading statistical informatics and biomedical journals such as JAMA, Bioinformatics, JAMIA, and MPG Digital Medicine. And I might mention that next Thursday, Chuan is scheduled to be jumping out of an airplane and doing a skydive. Chuan, yours.
Yeah, thank you so much, Ed. And thank you everyone for being here. Today, I will be sharing our recent work about evaluating prevent equation, which is a cardiovascular risk equation. And our evaluation is focused on the fairness and also the incremental value of incorporating social determinant of health. And this project is a collaborative project between Duke, NYU, Northwestern, and also the American Heart Association. And it is funded by the Doris Duke Foundation through a grant awarded to the AHA. And as you may already know, cardiovascular disease remains one of the leading causes of death in the United States and continues to pose a major public health burden. To guide the primary prevent efforts, multivariate risk prediction equations are now widely recommended by clinical guidelines. And this model evaluates a person's absolute risk of CVD over a fixed range of time horizon, typically 10 to 5 years. And this risk-based prevent framework is built on a very straightforward idea to match the intensity of the preventive interventions to the individual's predicted risk. For example, a higher 10-year risk might trigger like a lipid lowering therapy, while a lower predicted risk might lead to lifestyle part of consulting alone. Although the risk-based prevention has been a fundamental concept for over 2 decades, the models used to assess the CVD risk have continued to evolve, driven by the need for better accuracy, broader generalizability, and stronger clinical utility. One of the most commonly used model today is so-called pooled cohort equation. In short, we call that PCE. And that model was developed back in 2013 by the AHA and the ACC. The PCE model provides sex and race stratified risk estimates for ASCVD in white and Black adults. However, it has several major limitations. First, they only focus narrowly on ASCVD, do not capture the full burden of CVD disease, particularly with the rising incidence of conditions like heart failure. Second, they do not reflect the current trend in the risk factor or preventive therapies. And lastly, their generalizability is limited because their training data only contains white and black population. And in response to these challenges, the AHA recently convened a science advisory group. And from these efforts, the PREVENT equation were developed and validated. PREVENT equation is a modern, inclusive tool designed to estimate the total CVD risk, including subtypes like heart failure and stroke. And these equations were launched as part of the AHA-ACC guidelines released recently back in this August, making a major shift towards CVD prevention. And before diving into all these details, here I briefly outline my talk today. And I will not spend any time on PCE more due to the time limitation. And I will begin with a brief overview of the PREVENT equation. Then I will share the objective of two of our current study we conducted to evaluate a PREVENT equation. And the first study was using data from Truveta platform, so which is a large EHR platform containing data from hundreds of US hospitals. And this first study focuses on the fairness evaluation and also the subgroup performance. Then I will also cover a second study where we use Duke EHR data, and we evaluate the real-world reliability of PREVENT equation. And finally, I will talk about the implications and also our future directions. A little bit more about PREVENT equation. Over the last 2 decades, the landscape of CVD, cardiovascular disease, has changed a lot. And we have seen rising BMI and more pre-diabetes and also more type 2 diabetes, but also less smoking, and also right now people live longer. So that means our risk factor look different than before. At the same time, we are seeing more heart failure as part of the overall event. And also we see a drop in type 1 MI, and also we see more stroke cases. On the treatment side, statin use is up, and we now have newer medications that can help reshape the prevention of this disease. And more importantly, we now recognize how closely connected the heart, kidney, and metabolism and obesity. So this has led to a new focus on the CVD, kidney, and metabolic, which PREVENT is designed to address. So overall, we need new tools to reflect this shift. So that's exactly the PREVENT equation aim to do. And although the original PREVENT equation paper, they have been evaluated within, like internally and also externally. There are 2 major research gaps in the evaluation. Most of the validation study to date have relied on a smaller data set and haven't evaluated how well the risk model perform across different socially defined subgroups. And also importantly, there has been limited work assessing the real-world application of PREVENT equation, particularly how well the model behave when there are a lot of messy, especially there are a lot of missingness in the data, which is common in EHR. To address this, we use 2 EHR results. One is Truveta, another one is Duke EHR to evaluate the PREVENT equation. So now I want to talk about our first study. So where we evaluate the fairness of PREVENT equation using the Truveta data. This slide shows the workflow of this study. And for those of you who did not know about Truveta, Truveta is a large real-world EHR platform that aggregates the de-identified data from over 900 US hospitals and covering more than 120 million patients across very diverse geographic and demographic subgroups. And starting from left, we begin with the Truveta database, and we define a cohort of 550K adults who are eligible for the CVD risk prediction. And also we curated variables, and we also apply some data imputation for the social determinant of health variable. And finally, we got our data set and we split that into training and validation. And as I mentioned in the previous slides, we want to address two research questions in this study. The first question is, how fair is the original PREVENT model across different demographic and also the social groups? The second question is, does adding SDOH predictor to the model can help with the performance? And to answer these questions, we compare the original PREVENT equation with a retrained version that include or without include SDOH variable. And also we conduct subgroup analysis evaluating the model performance across sex, race, ethnicity, and also a set of SDOH-defined subgroup like insurance, home ownership, and income. The evaluation metrics we have been using include discrimination, calibration, and also fairness. And here are some more detail about how we construct our cohort. We followed the inclusion and exclusion criteria from the original PREVENT paper. And specifically, we included individuals who are aged 30 to 79 years and are free of CVD disease, and also have valid measurements for the key clinical variables, including SBP, creatinine, total cholesterol, HDL cholesterol, and also BMI. So these are the predictors of the PREVENT equation. We curate all these predictors within a predefined look-back window. And to do this, we need to first define an index date. So the figure on the right-hand side illustrates this design. And as you can see, these green dots represents the first encounter of the patient in the system. And the red dot represents the index date and when the follow-up begins. And here we define the index dates using the earliest available pair of SBP and creatinine value within 1 year. So which are the two most important predictors. And then we can identify the index date. We restricted the index date to they have to be between 2010 and 2018 because we want to have enough time for the look back window, and also we want to have enough time for follow-up. And after we define the index date, we apply a 1-year code period prior to the index date to find those prior CVD event, and then we can exclude those patients who already have event before the index date. And as you can see from this figure, the pink window shows the look back period when we want to define the baseline data, and the green window marks the follow-up period until the first CVD event or sensory. And in our analysis, in addition to the demographic subgroup, one important content is we also include SDOH defined subgroup. So where these SDOH variables were derived from Truveta, and Truveta they partnered with a vendor, and the vendor helped them impute some of the information. So each of the patients, they have this SDOH variable. And we organized the SDOH variable into 5 key domains. We have the economic stability, where we use the median income of the patient's residential area. We also have the education access and quality, so measured by the highest level of the individual's education. We also have the healthcare access and quality measured by the type of insurance. And finally, we have the neighborhood and the built environment measured by the dwelling type and also home ownership. And here are the models under comparison besides the original prevent equation. We consider a set of models. First, we have the original prevent equation, so where we apply that coefficient, the published coefficient directly from the model, and apply them to our cohort. And second, we retrained the prevent model, and both with and without SDOH predictor. That allow us to assess the incremental value of incorporating SDOH predictor into the model. So here we have 2 versions of the retrained model. And in the model without SDOH, we just refit the Cox model using the same set of variables that were included in the original prevent paper. And in the retrained model with SDOH, we augmented the original set of predictor with SDOH variables. And lastly, I want to make a note that competing risk modeling, which was used in the original prevent study, cannot be implemented in our setting due to the lack of cause-specific mortality data in the Truveta database. And to evaluate the model performance, we assess both the discrimination and the calibration. For discrimination, it was measured using the concordance index, which I think you already, most of you already know that, but I just want to revisit this definition because later we also incorporate a novel matrix. So here for the concordance index, it reflects the model's ability to distinguish individual at higher versus at lower risk. And here we use Bootstrap to estimate the 95% confidence interval for each model. For calibration, it assesses how closely the predicted risk align with observed event risk. And here we use the calibration plot. We also use the calibration slope. But beyond that, I also want to introduce 2 additional metrics we use to measure fairness. And on the left-hand side, it is a so-called percentile calibration plot. So this percentile calibration compares the observed event rate across predicted risk percentiles divided by subgroups. And you can think of it as a way to check whether the risk predictions are systematically over or underestimated across group. And I have a toy example figure here. And you can see group A consistently show higher observed event rate than the other group at the same predicted percentile. This pattern suggests the ranking disparity, where individuals in group A are systematically assigned lower predicted risk than equally or less at-risk individuals in other group. In addition to that, we also use a so-called cross-group concordance index. or in short, we call that XCI, which extend the traditional concordance index. So this metric was novel and developed by my colleague Matt Engelhardt from Duke, and also a set of investigators from Duke. Just a little bit more explanation of this novel metrics. While CI concordance index asks a question, if two patients have different event time, that the model rank the earlier event higher. So that is a question the concordance index asked. But the XCI, the cross-group concordance index, asks a similar but a little bit different question. So they are asking it across group. So for instance, I also have a toy example here in the right figure. We have two patients from two different groups. And here I use different color to represent the different group. We have blue group and also orange group. And also we have two versions of the ranking. On the left-hand side, we have the ranking by the actual event time. And also on the right-hand side, we have the ranking by the predicted risk. And so if we have two patients from the two group, like patient A from the blue group and also a patient D from the orange group, as you can see, patient A has an earlier CVD event than patient D. So based on the ranking from the left-hand side. And then we check whether patient A is ranked higher in risk than patient D. So when it is true across many such pairs, and so you will have higher XCI. But look at this example. So the ranking of the predicted risk is not consistent comparing with the actual ranking of the event. Then if there are a lot of this type of situation, you will get lower XCI. So XCI captures the proportion of the correct ranking across different groups. So that is one major difference comparing to the conventional CI. And so here I want to show the results. This table shows the baseline characteristic of our cohort. And I didn't put the characteristic of the original PREVENT paper here, but so this result closely measure it is very close to those reported in the original PREVENT paper, and supporting the generalizability and relevance of our validation population. And here is the discrimination performance. And actually in this figure, we have two parts. The right part shows the discrimination performance and the left part shows the calibration. But let's first focus on the discrimination performance. And where we use concordance index for the measurement. And overall, the original PREVENT model demonstrate a very strong discrimination with the C index ranging around from 0.76 to 0.8 in most of the groups. And we also retrained the model with and without SDOH incorporated in the equation. And as you can see from this right side of the figure, across all the subgroups, adding SDOH did not meaningfully improve the discrimination. In fact, the C index remained nearly identical across all the three versions of the model. So that is original PREVENT, the retrained PREVENT, and also retrained PREVENT with SDOH. All these three versions of the model, they perform very similar. So this suggests that although SDOH may capture some structural disadvantage in the dataset, they do not substantially improve the model's ability to rank individuals by risk beyond the clinical factors, which are already included in the prevent equation. And here, this slide shows the calibration performance measured by the calibration slope on the left-hand side. And as you know, so the ideal calibration slope is 1. Here we use the red dashed line to show the ideal calibration slope. As you can see, the original prevent model showed a wide range of calibration results across subgroups. And when we retrained the model using our data set, which was shown in medium blue, we saw some improvement in the calibration slope for the majority of the group. So that is expected, because we use our local data to retrain the model. But when we add SDOH predictor to the equation, which is shown as the light purple in this figure, and this only result in some marginal improvement in only a few subgroups. And also we even see some worse result in other subgroups. So we don't have consistent or meaningful gain by adding SDOH to the equation. And remember, in addition to discrimination calibration, we also have the fairness assessment. These slides show the subgroup calibration plot evaluating how well the predicted risk align with the observed outcome across different subgroups. And overall, most subgroups shows consistent calibration across these different group and across risk percentiles. However, the fairness disparity become more severe when we zoom in on specific subgroup. Particularly, we see that disparity in race and ethnicity subgroup. So here in that subfigure, we can observe visible calibration gap at a certain predicted percentile, especially between Asian and white. And also we see this gap in education. So that is for patients with no college education, the risk tends to be underestimated. And so remember, for fairness, we introduced 2 novel metrics. The second novel metric is XCI, the cross-group concordance index. And this slides summarize the XCI value. And XCI measure how well the model rank patients across different groups. And the finding is consistent with the calibration percentile figure in the previous slides. And we observe the notable disparity in subgroup ranking performance, especially across education, insurance type, and also race and ethnicity. So by looking at this heat map, if you see more variation in the color, so that means we have more disparity across subgroups. And in contrast, for the rest of the subgroup, including the address ownership, the dwelling type, and so we have more stable fairness with low variation across within groups. And finally, for study 1, these slides summarize the key findings. And first, we found that prevent equation demonstrate consistent fairness across a wide range of demographic and social subgroup. And just a recap, to assess the fairness, we introduced 2 novel evaluation metrics. One is the percentile calibration plot. And also we introduce XCI, where we evaluate whether individuals with earlier events consistently rank higher across different subgroups. And finally, we tested whether adding SDOH predictor, such as income, education, housing, insurance, could improve the model performance. But our final result is the gain in both discrimination and calibration are minimal by incorporating SDOH predictor. And after talking about the first study, I want to switch to our second study, where we evaluate the real-world performance of prevent equation using the data from Duke Health. So while study 1 focused on fairness, study 2 asked a different but equally important question. How well does prevent model perform in a real-world system where we have a lot of missingness, we have a lot of messiness of the data? So this study leveraged EHR data from Duke Health and spanning from 2014 through 2024 to evaluate the performance under different level of data completeness. We define 2 cohorts, and we have a relaxed cohort, so where we allow a lot of missingness in the data, just to mimic the routine clinical setting, and where not all the patients, they have all the measurements across time. And also we have a so-called strict cohort, which is a more stringent cohort limited to patients who meet the original prevent equation inclusion criteria with complete data on all the required variable. Together, these 2 cohorts let us examine how robust the prevent model is when applied to the real-world setting. And so here is our cohort construction and also our sample size for both versions of the cohort. Both cohorts begin with over 1 million adult patients from Duke EHR. And for the strict cohort, after applying the full prevent inclusion criteria, and we end up with a cohort with 127K individuals. And on the other hand, the more inclusive relaxed cohort contain over 400K individuals, which reflects the real-world variability in the data completeness. And here we also show some baseline characteristics of the 2 cohorts. And also we compare that to the original prevent cohort, which we copy and paste from the prevent paper. And as you can see, our relaxed cohort included a younger and more racially diverse population, and with nearly a quarter identifying as Black, and also a notably lower proportion of white patients. On the other hand, for the strict cohort, it is more closely resemble the original development cohort in the prevent paper. But still, because of the special feature of the Duke population, it still showed greater representation of non-white individual comparing to the original prevent cohort. And regarding to the event rate, we observe lower event rate in the relaxed cohort across all the outcomes. So this is likely reflecting healthier population may have more missingness in the lab measures. And also, we compare that with the original prevent paper, the cohort, and we see it is very similar. The event rate are very similar, supporting our use of this cohort for the performance benchmark. And here I summarize the model we compared and how we evaluate their performance. And in this study, we evaluate 4 models. And again, we have the original prevent equation. So this is, we directly obtain the coefficient in the published paper, and we apply to the data without modification. Then we have different versions of local model, and we have the local Cox model. So that is just retraining the prevent equation using the same set of predictors, but we retrain that using Duke data. We also have the local DNN model. So where we implemented a neural network model with using the same set of predictors, but we train a neural network model. And we want to see if adding complexity to the model can help improve the performance of the model. And in addition to that, we have a recalibrated model, and we call that MLM, recalibrate prevent. So this model uses age, sex, and the original prevent risk score as input into a Cox survival model with XGBoost. And so we adapted from a recent publication to do this recalibration. And for evaluation metrics, we focus on this 2 set of evaluation because this paper is not about fairness. So we only evaluate the discrimination and the calibration performance. This radar plot compares the model's discrimination performance measured by C-index between the relaxed cohort and also strict cohort across different subgroups. As you can see, each axis on this radar plot represents one combination of subgroup. And overall, the impact of missingness in the relaxed cohort is minimal. Most of the subgroup, they show very similar C-index value between the 2 cohorts, suggesting that the model's ability to discriminate is robust to different level of data missingness. And interestingly, the relaxed cohort even show higher concordance index in some of the subgroup. And so this radar plot compare the C-index across, still across different subgroups and also across different models. And we use different color to represent different models. So if you can still remember, we have 4 models under comparison, including the original prevent, the local prevent, the local deep learning model, and also a recalibrated version of the prevent. We observe similar discrimination performance across all these model variants. And notably, the prevent model perform comparably to both locally retrained and recalibrated model. So this consistency suggests that local adaptation provided very limited incremental value in terms of the model discrimination performance. And because of the time limit, I didn't include the calibration figure here. But for the calibration, similar to our finding in the first study, we do see improvement in the locally trained or recalibrated model in the calibration, which is expected. But across different versions of the local adaptation, we did not see any improvement by using like more complex deep learning model. And here, this slide summarizes what is new and also the takeaways of our second study. And first, our primary contribution is emphasizing the real-world applicability of prevent equation. And secondly, we compare two analytical cohorts. One is a relaxed cohort, and also another one is strict cohort. And we didn't see a lot of improvement or difference across different cohort. And finally, we explore the local adaptation, comparing the original prevent model to the Duke-specific version, including the retrained model and also the deep learning model. We didn't see improvement in discrimination by do the local adaptation or by increasing the complexity of the model. And before closing, I want to take a moment to acknowledge the many people and organizations that make this work possible. And I'm grateful for the contribution of our co-authors and also advisors listed here. And also I want to thank Duke AI Health and the administrative team of Duke AI Health. And this study is truly collaborative, involving multiple institutions, including Duke, NYU, Northwestern, and also AHA. And finally, I want to acknowledge the Doris Duke Foundation, whose funding supported this research. And also, I want to give thanks to my mentor, Dr. Michael Pensina, for his guidance throughout the whole process. And this brings me to the end of my talk. Thank you for your attention. And if you have any question, and I would like to discuss more with you.
Thank you. This was very interesting. We have a bunch of questions that have been queued up. Let me start through the list. I will invite my students to join in as they see fit. The first one is there other data, such as nutrition and exercise, which was not available that would impact your study?
Yes, I think this diet and exercise data is available in the cohort in both Truveta and Duke HR, but we did not incorporate that in our predictor. I think it will be very interesting to expand our set of predictor and see if these variables, they can further improve the performance. But I just want to clarify, this data are available, but we didn't use that in our prevent equation evaluation because for their original model, they do not incorporate these variables.
Okay, and I will remind you, there are people in library science who have been listening to this, and one of them asks, when you say FAIR, F-A-I-R, are you applying principles based on data that is findable, accessible, interoperable, reusable, and also trustable, or is it a different idea in your mind or a different term?
Yeah, I know that FAIR definition, this acronym that represents this principle. But in this analysis, we are not looking at this broader definition. We only talk about the algorithm bias. So like if the performance of the algorithm are equally well across different subgroups. Yeah, but that can be that is related to the broader definition of this FAIR principle.
Got it. So all right, so let me ask a little bit, sort of a related question. At one point, I noted that you did some social determinants of health imputation. Can you explain that a little bit?
Yeah, I didn't do the imputation. Sorry for the confusion.
That's
But
all right.
Truveta platform, so Truveta did the imputation. So let me go back to the slides. So for the first study, we use data from Truveta. And the Truveta, this platform, they partner with a vendor. And the vendor did the imputation for the SDOH. And what they do is they use zip code. And so to get the area-based measurements for the individuals. And also they develop some algorithm to impute the patient level. SDOH. But the vendor didn't give us sufficient details like how they do the imputation. So we didn't provide that in our manuscript. But basically, so a third-party vendor, they do the imputation for SDOH based on the zip code and other information.
Okay, at the risk of losing my place, I'm going to take some of the questions out of order in the chat. Would combining demographic attributes, for example, sex and race together for subgrouping, surface more fairness issues?
So can you explain more about this question?
Yeah,
Max,
it's
you're
my
the one who
question.
asked it.
So if you go to the slide on the fairness disparity on study 1, I can see, I think I cannot remember the slide number, but the one with the like other subgroups like the sex and the race and everything.
This
Like
one,
the bar charts, the one with the bar charts.
the bar chart,
Yes, this
this
one.
one.
Yes. So I can see on the left here you have like male, female, right? And what if you combine like let's say sex and race, for example? Would some of the subgroup like perform even worse or perform better?
When you say combine, you mean make it more granular, right?
Yeah, kind of. Like let's say if you combine the like the one that perform poorly here, like black with public insurance, for example, would they like perform even worse?
Yeah,
Yeah.
we do see that. So we try different combination of the subgroup. Like I think we think black male, the performance is even worse. Yeah. So yeah.
Okay.
But we didn't show that in our main result because at first we just run everything we can, and then we focus on the main story. But so when you talk about disparity, you look at the left-hand side of this figure, right? That is calibration slope. But we didn't see a lot of disparity in the discrimination performance. So that is the right-hand side of the result. So I do want to emphasize this part. So about discrimination, so prevent equation generally perform well across different groups.
Okay, so you need to do a little bit more, let's say a little bit more calibration for the black subgroup, for example, right? But
yeah. That
Okay.
makes sense because usually for calibration, and we use our local data to recalibrate the model, right?
I see.
Yeah.
But here, for example, the public insurance, I guess it's Medicare perform worse, and also like the same in the Duke study as well. I saw the radar chart is perform worse than other groups. Do you like mitigate this in some way, or do you avoid using this model in this group with low discrimination performance?
I think we can still use this model, but we need to use that with cautious. With caution, we need to do some recalibration. So for some specific subgroup.
So all right. So let me, Max, I'm going to get back to one of your other questions, but first, I think this is sort of related. Do you think that if you took different sets of data of the Duke sites, your results would change? What is the impact of the differences in sites that might have an impact on results?
Sorry, can you repeat the question?
I'll try. Ed posted this and then ran away. Do you think if you took different sets of the Duke sites, your results would change? We'll start there.
Different sets of Duke sites, you mean the hospital, different hospital?
Yes. I think he's implying that there may be different, perhaps some variation in procedures, perhaps variation in the patient population.
So I don't think so, but that is a good question because I think although the population can be different across the three Duke sites, right? But the distribution of the predictors used in the prevent equation, I think they should be similar across different sites. So there might be some differences for other data, But for those predictors, so including BMI, SBP, those kind of things, I think the distribution across different sites should be similar. Then the result can also be similar.
Okay. And so
That is my guess. Yeah.
that's your supposition. Am I?
Mhm.
Okay.
Yeah.
All right. And you think that might have, in answering his second question, which was implied in your answer, that approach might have an impact on the difference in sites as reflected in results.
Yes, I think so.
Okay. All right. All right. Let's go back a little bit now. So as Max put it, and he can amplify if he would like, any possible reasons for the fairness disparity in study 1? Could it be due to underrepresentation in the training data set? For example, from lack of access to healthcare, lack of data collection, and so forth? Or is it explainable by biological phenomena?
I think it should be like different level of access to the healthcare. So like for certain type of patients, they have lower level of access to the healthcare. So the sample size in the training data are smaller. So that causes the algorithm bias. I don't think it can be explained by biological reason.
Okay. And then he noted in the Duke study, Medicare patients got really low C-index scores. How did you mitigate this? Should we avoid using this model for this subgroup?
I think we may need more like better data quality for this subgroup. So like maybe in this subgroup, because of the lack of access to the healthcare, so the data quality is not as accurate as the other group. I think we need to mitigate the bias from the root, but not avoid using this model in this subgroup. And also, when you see very low, it is actually not very low, right? Let me see. You are talking about the Duke study.
In a relative sense, it's low.
Yeah.
But only in a relative sense.
Let me see. So the lowest level here is 0.6. So it is not from 0. It is not from 0.5. So it is 0.6. I think it is still have value in prediction. I think we can still use that, but with more caution.
Okay, well, let me ask a purely process question. What statistical tools did you use to conduct your data preparation as well as your analyses?
Do you mean what statistical software or what model did I use?
Software.
I see. And for Truveta, because they have their own language, and we use a similar language like R in Truveta. And at Duke HR, we use R to do our data preparation and also for most of the analysis. But for Duke HR, we also implement a deep learning model. So for that part, we use Python.
Okay. Thank you. I'm asking that for my students. So based on your presentation today and the research that you're conducting, what can you see could be the sort of clinical implications of this? How might this change the practice?
Yeah, I think although one missing piece from my presentation is I did not compare the result with PCE model, just due to the time limit and the speed space limit. But in our manuscript, we do compare that with the PCE model. So although you still see some discrepancy across subgroup, but the overall performance is much better than the PCE model. So if you can still remember, PCE is the original model for CVD risk. And I think the insights, the implication of this study is prevent equation is a better model than PCE. And because PCE has been widely used, and prevent equation should be a shift focus and to be used in the future as also supported by the guideline. But there is also some room for improve beyond prevent equation. So like right now, we are also incorporating other predictors, like the data obtained from those device measurements, and to incorporating some functional features from the patient. And also, we have been working on machine learning methods to try to reduce this bias across subgroup, like we use transfer learning or federated learning, try to borrow information and also account for the heterogeneity across subgroups. We are hoping that it can result in another version of prevent equation.
So do you think then that there are other clinical conditions that this approach could be helpful with, and do you have plans to do that?
You mean other clinical condition? You mean other disease outcome?
Other than cardiovascular disease?
And when you say this approach, do you mean this prevent equation or our evaluation methods or our machine learning model to resolve the issue encountered by prevent equation?
So I'm asking this in the context of the prevent data resource and looking at the variety of data resources that are currently available. Could this approach be useful for those different kinds of data and different kinds of issues?
Yeah, thank you so much for the clarification. Yeah, definitely. I think this approach can be applied to a broader range of diseases because I think previously when we evaluate a risk prediction model and we only focus on discrimination and calibration. So there is, I think the needs for novel metrics of fairness is underestimated, and we can emphasize more on the fairness. And also, in addition to the commonly used demographic subgroup, we should always incorporate SDOH subgroup. And so I think that is a trend right now to explain the disparity in the model performance. Because some of the disparity we observed in race and ethnicity can be better explained by interaction with SDOH subgroup. Yeah, I hope that answers your question.
Yes, actually, it's an optimistic approach.
Thank you.
All right. Seeing no other questions coming in, I thank you, Dr. Hong. This was a very interesting study and a very interesting presentation.
Thank you so much. Thank you, everyone.
Thank you. Keep up the work.
Thank you.